Hello students, this is Dr. Udhayan, Assistant Professor from Department of Orthodontics and Dentofacial Orthopedics, Vinayaka Mission Sankaracharya Dental College. Today the topic is on Crouzon syndrome. Crouzon syndrome, we have a contents of introduction, classification, pathophysiology, diagnosis, clinical features, management and conclusion. Crouzon syndrome. What is Crouzon syndrome? The term craniofacial anomalies literally encompasses all congenital deformities of the cranium and the face. More specifically, however, the term has come to imply congenital deformities of the hard tissue, the head that interfere with physical and mental well-being. Most craniofacial anomalies and dentofacial deformities result from inherited mutations and aberrant environmental modulation of multiple genes. Crouzon syndrome is the most common craniofacial dysostosis regarding to the Apert syndrome or any other syndromes which is prevailing. Crouzon syndrome is an autosomal dominant disorder with complete penetrance characterized by premature synostosis of coronal, sagittal and lambdoid sutures that begins in the first year of life. It was first described by a French neurosurgeon Octave Crouzon in 1912. Crouzon syndrome occurs in approximately 16.5 cases per million live births, that is 1:60,000 ratio. It is considered the most common craniostosis syndrome as it represents approximately 4.8% of all craniostosis cases at birth. In this topic, we will discuss about etiology, clinical features, diagnosis and management of Crouzon syndrome. Proper treatment is not there for a Crouzon syndrome patient, but a management can do the best for the patients. A normal timing of suture closure is a very important thing to be noted here. So suture closure in humans, as on there is cranial sutures, that closure begins in the year of 2 years to the years like the months and years. The facial sutures, parietal, frontomaxillary, frontozygomatic, zygomaticotemporal, zygomaticomaxillary, frontonasal, nasomaxillary. The closure begins in years. That is, these are in years. The metopic, sagittal, coronal, lambdoid and squamosal, spinofrontal, spinoparietal, spinotemporal and masto-occipital. These are the important suture timings, that is the closure of the sutures are in a very specific tabular column. The Virchow's law. Virchow's law formulated the classical theory and he stated that premature fusion of cranial vault, that is craniostosis, inhibits normal skull growth perpendicular to the fused suture and a compensatory growth occurs at the open sutures. The general direction of growth after synostosis is parallel to the fused suture. The Virchow's law is nothing but if the cranial vault suture that inhibits normal skull growth, if the premature fusion of the suture occurs, there will be inhibitance or inheritance of the growth of the normal skull. Depending on the it will have a parallel growth in the opposite side. That is the Virchow's law. The pathophysiology of Crouzon syndrome occurs due to a genetic variation like mutations, and it is one of the FGFR genes most commonly occurred because of FGFR2 gene, which causes the genetic mutation of the Crouzon syndrome. It also can be environmental, and the genes provide instruction for creating proteins that play a critical role in many functions of the body. When a mutation of a gene occurs, the protein product may be faulty, inefficient or absent. Depending upon the function of the particular protein, this can affect many organ systems of the body. This FGFR gene is a genetic mutation that affects the patient in all the sutures and different systems of the body. Classification of Crouzon syndrome based on the phenotype, that is based on the type of vault suture synostosis. That is, he has classified, this is a classification given by Lu in the year 2020, which is a recent classification. It is also classified as class 1, class 2 and class 3 and class 4. Class 1 is nothing but coronal and lambdoid synostosis, and class 2 is sagittal synostosis, class 3 is pan synostosis and class 4 is others, that is metopic and unilateral coronal synostosis or bilateral coronal synostosis or bilateral coronal and sagittal synostosis. Everything comes under class 4, that is other classifications. Clinical manifestation of Crouzon syndrome. In general, psychomotor development is normal and their mental ability is usually within the normality. However, some reports of mental retardation have been related to the restricted brain development secondary to increased intracranial pressure resulting from premature synostosis. The clinical finding in a Crouzon syndrome patient will emphasize on the intracranial pressure which should be released, so that during the childhood the releasing the sutures which is being prematurely fused will lead to a management of the Crouzon syndrome, that is the intracranial pressure will get reduced and the proper development of the skull will happen. This is known as the Crouzon syndrome management. The cranial features, premature craniosynostosis, that is nothing but coronal, sagittal, lamboid and metopic sutures. These are the premature craniosynostosis, nothing but premature fusion of the sutures. A convexity in the anterior frontanale. This is the anterior frontanale. You could see the anterior frontanale convexity is seen, and frontal bossing. This is the frontal bossing. Patient is having frontal bossing in the forehead region. And high and large forehead. Forehead can be seen as large. That is the forehead will be excessively in ratio, it will be large. And flattening of the occipital region. The occipital region is flat. It should be like a round, but it is flat. Flattening of the occipital region and digital markings of skull and widening of hypophyseal fossa. These are the cranial features. The synostosis of the sagittal suture limits lateral skull growth, redirect growth antero-posteriorly. The skull growth here is limited in the lateral aspect, whereas antero-posterior is grown. That is redirecting the growth antero-posteriorly is known as scephalocephaly. Whereas bilateral synostosis nothing but premature fusion bilaterally of the coronal sutures limit the antero-posterior growth. That is the antero-posterior growth, it will be limited here, and the growth of the calvaria producing a pointed or short skull will be happening in this patient. It is known as brachycephaly. Okay, premature fusion of the metopic suture leading to a triangular forehead. You can see a triangle forehead here, and the merging of the two frontal bones leads to transverse growth restriction and parallel growth expansion. It is known as trigonocephaly, trigonometry. That is, it is nothing but dealing with triangles. This is the triangle shaped forehead. Premature synostosis of one side of the coronal or lamboid suture causes obliquity of the skull. That is, obliquity is nothing but the skull will have a deformity, that is known as plagiocephaly. Okay, ocular features. Ocular features you would have seen in most of the conditions or patients in our hospital, whereas shallow orbits with bilateral ocular proptosis and hypertelorism with divergent strabismus and nystagmus, cloboma of the iris, keratoconjunctivitis, visual disturbances or loss of visual accuracy. You could see the bilateral ocular proptosis in this case, whereas you can also see a cloboma of the iris. You can also see mid-face region, the cranial features. We have seen cranial features and ocular features. We are going to see the mid-face. Mid-face region, there will be maxillary hypoplasia. You could see the maxilla deficient here, and the hypoplastic zygoma, zygomatic malar prominence is absent in this case. You can see the patient having a maxillary hypoplasia and zygomatic, there is hypoplastic zygoma and paranasal sinuses. Concave facial profile, the patient will have a concave facial profile here. This is convex. Okay, intraoral manifestation. In these patients, the intraoral manifestation, as a dentist we have to know about the intraoral manifestations of the patient. In the case of Crouzon syndrome, mandibular prognathism, maxillary hypoplastic, that is maxillary retrognathism, and reverse overjet, which is known as the class 3 tendency, and V-shaped maxillary dental arch. A narrow, high or cleft palate and biffid uvula can be also seen as well. Occasional oligodontia, macrodontia, peg-shaped laterals or any other tooth, and widely spaced teeth have been reported. Diagnostic procedures of Crouzon syndrome will majorly seen in the radiographs. Radiographs in the nothing but 2D radiographs can be seen. The craniostosis can be suspected in prenatally based on indirect signs visualized using 2 or 3 dimensional ultrasound, magnetic resonance imaging or computed tomography. Prenatal 2D ultrasound diagnosis aims to visualize the cranium, the shape, allowing the calculation of the cephalic index. Regarding to the differentiated face morphology, common characteristics of Crouzon syndrome such as hypertellurism, ocular proptosis and big nose can be identified by ultrasound scan. Radiographic diagnosis. The earliest radiographic signs of cranial suture synostosis are sclerosis and overlapping edges. Sutures that normally should look radiolucent on the skull film are not detectable or show sclerotic changes. There will be a premature fusion that is leading to the sclerotic changes. Rarely the facial features may manifest before evidence of sutural synostosis. Premature fusion of the cranial base leads to diminished facial growth. In some cases, prominent cranial markings are noted, which are also seen in normal growing patients but are prominent because of an increase in intracranial pressure from the growing brain. The main appearance, that is the copper beaten metal appearance, is seen in this patient. This is the copper beaten appearance. These markings may be seen as multiple radiolucencies appearing as depressions, so-called digital impressions of the inner surface of the cranial wall, which results in a beaten metal appearance. You can see the beaten metal appearance here, and here also you can see the beaten metal appearance. The prenatal diagnosis of Crouzon syndrome by 2D ultrasound findings of brachycephaly proptosis with easily visible palpebrae, depressed nasal bridge and a big nose in a fetus at 32 weeks of period of gestation can be seen as a prenatal diagnosis. The confirmational diagnosis of the Crouzon syndrome patient is finally confirmed by molecular diagnosis. Molecular diagnosis is nothing but the diagnosis investigation made from the genetic basis. Specifically, mutations in FGFR1, 2 or 3 genes are investigated by amniocentesis, that is it is done in the gestational, the intrauterine life of the fetus. Chronic villus and sampling or pre-implantation diagnosis are the confirmational diagnosis as the technologies have come in the future ages. And the differential diagnosis of Crouzon syndrome includes simple craniostosis as well as Apert syndrome, Pfeiffer syndrome, Carpenter syndrome and Schnitter-Schouten syndrome. Patients with associated acanthosis nigrans can have FGFR mutation, FGFR3 mutation. These acanthosis nigrans and Pfeiffer syndrome, Carpenter syndrome and Apert syndrome, these are the differential diagnosis of Crouzon syndrome. The Apert syndrome, it has a similar finding to those of Crouzon syndrome, but with symmetric syndactyly of the hands and feet, usually involving the second, third and fourth digits of the hand and feet. These are the examples of the Apert syndrome. You can also see the radiographic findings in this slide. And in case of Pfeiffer syndrome, broad thumbs, broad big toes and partial soft tissue syndactyly of the hands and feet will be present in addition to the features of Crouzon syndrome. These are the examples of Pfeiffer syndrome. The broad thumbs and broad big toes are seen here. The Carpenter syndrome. The Carpenter syndrome is nothing but a clover leaf skull. Often associated with this defect is marked cranial asymmetry described as clover leaf skull anomaly caused by craniostosis. There is a mild downsloping of the eye. The eyes are also involved in Carpenter syndrome. Small mandible, high arch palate and mental deficiency are the different features of the Carpenter syndrome. The Schnitter-Schouten syndrome, mid-face hypoplasia, hypertellurism, strabismus, a thin pointed nose, cleft palate, cutaneous syndactyly of certain digits, finger-like thumbs, brachydactyly with a significant shortening of the little finger and a nail dysplasia. You can see the brachydactyly here and These are the other differential diagnosis of Crouzon syndrome with the acanthosis nigrans. You can also see the acanthosis nigrans in these patients. And the management of Crouzon syndrome is given by Nurko et al. By a protocol in the year 2004. During the childhood, the orthodontic therapy aims to deal with ectopic eruptions, delayed tooth emergence, crowding, and posterior crossbite in patients with mixed dentition in the ages of 5 to 12 years old. Recommended methods are the extraction, use of lingual arch, that is TLA, and or fixed appliances, and a palatal expansion with the RME or any other palatal expansions. In patients with suture closure in the palate, segmental surgery in the form of Lefort 1 is proposed as an alternative to palatal expansion, and also combined with orthodontic fixed appliance therapy. The preparation of the mid-facial advancement, which usually takes place between 6 to 10 years of age, requires extraction of primary teeth, fixed orthodontic appliance for acrylic surgical splint holding, and full dimension rectangular arch wires, while a removable retain is suggested after surgery to prevent the relapse and the other complications. Later during adolescence, the patient is prepared for orthognathic surgery. The orthognathic surgery, which requires permanent dentition and skeletal maturity in the age of 13 to 15 years for girls and 15 to 17 years for males. The orthodontist align the teeth of each jaw without worrying about the reverse overjet or dental occlusion using fixed appliances, and arch compatibility is checked on dental cast. Mock surgery is done. You all know that mock surgery will be done before orthognathic surgery is planned, and we orthodontists also align the cases with the rectangular arch wires in place, and we do a mock surgery for the treatment to be done. And after the surgery, the orthodontic appliances facilitate in preventing the to develop in the occlusal harmony, and full dimension archway is placed, and final records should be taken, and the records involves the radiographs and dental casts. Post-surgical orthodontic treatment therapy starts approximately 4 to 6 weeks after the surgery. That is, the post-surgical orthodontics involves the settling of the occlusion and properly maintaining the occlusion and giving the patient a good occlusal harmony. Vertical elastics are used to settle occlusion and prevent relapse or shift different from centric relation. This procedure lasts about 6 months, and then retainers use full time or for 12 months of after surgery. The distraction procedures, these are the distraction procedures. The RID system, you all know that RID system is nothing but rigid external distraction device. These patients undergoing Crouzon syndrome or any other syndrome can be done with a distraction protocol. The surgical techniques, the front nail, the frontal bone can be distraction done by a distraction osteogenesis. The osteotomy lines are almost identical to those of conventional fronto-orbital advancement, except for lack of supraorbital osteotomy and tongue in groove osteotomy. These are the distraction sites where there is a distraction osteogenesis going to take place in these areas, and custom-made internal distraction devices are placed in the bregma and bilateral temporal regions after 5-day distraction is initiated. These are the custom-made internal distraction devices which can be used in the patient for distraction purposes. Distraction protocol: after 5 days the distraction has been initiated. The distraction devices were activated 2 times daily. The distraction devices approximately extend about 0.5 mm per activation. In this manner, the desired advancement was achieved in 13 days. The devices were left in place for 3 additional weeks for retention. That is, there will be a bone development in the region. The distraction devices were removed after general anesthesia has been administered and been induced in the patient. Surgical access was made through the initial incision. The initial incision which is made during the surgery of the patient during placement of the distraction devices is the region where the initial incision made and the devices are removed. These are the post-operative course. The patient post-operative course was uneventful and good cosmetic results were achieved in the patient. These are the article case reports which has been mentioned here. The advantages of fronto-orbital advancement by gradual distraction. This is the case where you can see the fronto-orbital distraction has been done. Drawbacks of this technique: the inability to reshape the fronto-orbital bone. There is no definitive treatment for Crouzon syndrome, but there is a lot of management protocols for the Crouzon syndrome can be done, and there are drawbacks of this of the technique involved in this management protocols, which is minimal in the management section. The necessity of an additional operation to remove the distraction device and the possibility of a extradural hematoma formation during distraction is also a drawback in this Crouzon syndrome management. Conclusion: a patient with Crouzon syndrome need long-term management by scientists of various specialties. Facial and functional malformation in individuals with Crouzon syndrome could be significantly improved after a series of surgical and orthodontic procedures in almost all the cases. According to the above mentioned protocols, the surgical treatment of craniofacial hypoplasia is obligatory. However, the role of orthodontist is crucial both before and after surgery to reach the desired treatment plan goals. Thank you for your patient listening. Thank you so much, students.